Attendees are in listen-only mode.
Hello, everybody. So good morning to everyone on the West Coast and almost just to the afternoon, everyone on the East. We're very excited here at Fight CRC this morning, afternoon, to welcome you all to the 2016 ASCO in review. Just a quick note about our ASCO presentation today. As many of you know, ASCO is a conference where we bring in 40 to 50,000 people from throughout the world to talk about the latest advancement in research and clinical practice for cancer care. So we're very excited to attend this session every year and bring back what are the biggest high points around colorectal cancer advancements for treatment research and helping in the survivorship domain. We're ready this morning to go ahead to start our webinar, and I say this morning as I'm Andy Dwyer from University of Colorado Cancer Center, Colorado School of Public Health. In Colorado, working in a joint appointment with Fight Colorectal Cancer. And I want to say a special thank you to Michael Sola and Sharon Worrell, who are part of the Fight CRC team, as well as Danielle Burgess and Andrew Wortman for running a lot of the social media components today. So thank you, team, and everyone at Fight CRC for helping bring this webinar into fruition. So we're going to go ahead and get started this morning. I'm very excited to have all of you joining. As we hear Dr. Emily Chan from Vanderbilt, who is an immunologic expert in the field of oncology and is both a PhD prepared as well as physician at Vanderbilt, who does a lot of work in this sphere. And we're very excited to have Dr. Chan working with us, as she's also one of our work group members for the immunology efforts that we're taking on in memory of Gordon Cole, working with the Cancer Research Institute. So before we get started this morning, we wanted to just remind you all that all of our resources are here within Fight CRC, the website, which you all have access to, and then we'll receive reminders in terms of how to access these resources, as well as a follow-up evaluation for today. But just a quick shout out that our Guide in the Fight, which is one of the most popular patient education pieces, is available, updated on the website, as well as other materials such as the podcast, which also covers specific areas of discussion around colorectal cancer topics, as well as our ongoing webinar series and also our blog series dedicated to research and patient education. Just a quick note, a reminder that, of course, Fight Colorectal Cancer brings all of the latest information to all of you relative to what we know are the most salient research themes, treatment themes, as well as cutting-edge research information. But again, this is in no way, shape, or form replacing direct medical care. And if there is any sort of emergency, we do encourage at all times to dial 911. And just a reminder that, of course, in terms of the treatment decision-making, that's really up to the caregiver, family members with the clinical team, as Fight CRC is really dedicated to bring the information to help inform, but does not actually play a service as a provider. Next slide. So with that, as I mentioned before, Dr. Emily Chan is a professor at Vanderbilt, particularly working in the HEMONC. We're really excited to have her, as she's definitely done a lot of fantastic work in preparation at Memorial Sloan Kettering, clinical interest particularly in the area that we are interested in terms of the colon and rectum, and then does a lot of work in the GI space in general. Research particularly really thinking about immunology as well as the tumor markers and thinking about predictive responsive for therapies. So that made Dr. Chan, who's been working with us over the last year, a perfect candidate to bring home the most salient issues around colorectal cancer advancements. And I do want to also just mention today that we have done a good bit of coverage throughout the ASCO preparation, as well as what we consider ASCO season, and survivorship month is June, having Destry Deming as well as Tom, the incredible scientist, cover what are the biggest issues in helping us prepare. So I want to do a special thanks to Dr. Chan, as well as the rest of our medical advisory board members, as well as Tom, for all of the work that they've done to help bring out the most important issues as we come into today's presentation. Just a quick reminder that as we get ready to move ahead, that the chats feature is available. So if you're asking questions, we do all questions But we do ask that most of the questions are related to specifically the science, the research, and not specific about an individual treatment decision or question. As noted before, we want to ensure that that's really a discussion that's held with you and your clinical team. But we really would love to have as many questions today relative to the science and the advancements which Dr. Chan is going to present for us. So Dr. Chan, are you ready to begin?
Yes.
Okay, very good. Thank you.
Can you see my screen?
Yes.
Okay, I'm still. Are you seeing? Are you seeing my desktop screen?
Here we go. We are
Because I'm
seeing
not.
abstract 3501.
Oh, okay. So you are seeing my desktop screen?
Yes.
Okay. Are you seeing the other stuff on my desktop?
Yes.
Just yes.
Okay. Let me clean that up a little bit then. Okay. All right.
If you go to slideshow view, I think you should be good.
Okay. Hold on.
Do show
Slideshow.
slideshow. There you go.
Okay.
There
All
you go.
right.
You're
Got
good.
it. All right. Well, thank you all for taking time out of your busy day to come listen to us. So I'm going to talk about some highlights that happened at ASCO, and ASCO can be a bit of an overwhelming meeting to hear about everything. So I thought I would focus on four what I consider key trials that were presented at ASCO, and then we'll talk about a few other things as well. I'm going to talk about two immunotherapy trials that I really think are very important in terms of where the field for colorectal cancer is going. And then I'm going to talk about two chemotherapy trials that give us some information on how we should or shouldn't be using the drugs that we currently have. So the first trial I want to talk about was abstract 3501, and this is the Checkmate 142 trial looking at nivolumab and ipilimumab in metastatic colorectal cancer, and these are only interim results. And so if any of you had been at the last ASCO, you know that there was data presented about pembrolizumab, which is a similar compound in microsatellite unstable colorectal cancer and in other tumors as well that were microsatellite unstable. And there were some very intriguing responses seen in that small trial. So as we know, colorectal cancer, a small proportion of them are microsatellite unstable, or what we call MSI high, microsatellite instability high. In metastatic disease, it's not that common. It's only in about 4% of the metastatic colorectal cancers. Microsatellite instability high patients are the ones that have a hereditary syndrome that we call HNPCC, hereditary non-polyposis coli, and these are folks who develop colorectal cancer at a younger age, are what they have is a defect in the repair of the DNA, and that leads to a high mutational burden. And these tumors also have an increased neoantigen load. So nivolumab is a fully human IgG4 immune checkpoint inhibitor antibody, and it binds to PD-1 receptors on T cells. This is programmed DEF1 receptors on T cells. And so what happens is that it disrupts the signaling and it restores anti-tumor immunity. So the interesting thing about these immunotherapies is that the drug itself doesn't fight the cancer, but what it does is that it tweaks the immune system to allow the immune system to recognize cancer cells as cancer and as foreign, and it allows the body's immune system to fight the cancer. And ipilimumab is an anti-CTLA-4 antibody, and it also tweaks the immune system. And there are studies in other diseases that show that nivolumab and ipilimumab together can enhance T-cell anti-tumor activity. through different pathways, but they work together. And we know from other diseases that the combination can be more effective than the drugs as single agents. So in this clinical trial, they wanted people in fairly good health. So ECOG performance status of 0 to 1. These are folks who are up and performing chores. They might be still going to work. They're not people who are tired and sitting around in bed or in a chair for more than half the day. And they were looking at a population of patients who had progressed on at least one prior therapy for the microsatellite, for the MSI high population, and then, or they could have not had chemotherapy as long as they refused chemotherapy, and that is certainly not most patients with metastatic colorectal cancer. Or they could be patients who were intolerant of chemotherapy that they had before. The MSI status was determined locally, but there was central checking of the MSI status as well. But to get onto the study, you needed the MSI status that was determined locally. The study excluded people with brain disease, and any other prior malignancy within the past 3 years. As in these immunotherapy trials, it eliminated people with active or a history of autoimmune disease because you don't want to reactivate an autoimmune disease by revving up the immune system. It also eliminated folks who needed immunosuppressive medications because, of course, if folks are on an immunosuppressive medication, it can interfere with how these drugs are supposed to work. And folks on this trial could not have been treated with prior therapy that targeted T-cell co-stimulation or immune checkpoint pathways. Now, while the primary goal of this study was to see how these drugs worked in the MSI high population, there was an independent safety cohort in the microsatellite stable population. And in this population, it was for third line or later non-MSI high metastatic colorectal cancer. And they started off with a dose of nivolumab at 1 milligram per kilogram and ipilimumab at 1 milligram per kilogram. And they got that for 4 doses 3 weeks apart each, and then they got treated with nivolumab 3 milligrams per kilogram every 2 weeks. And so they put folks on this trial, and then after following them for 6 weeks, if that was a safe dose, then they randomized to one of 2 different doses of ipilimumab and nivolumab combination with 10 per arm. And the idea of this safety cohort was to choose what would be the right dose to explore in the microsatellite in the MSI high population. And in the MSI high population, so the plan was that they would start off with nivolumab 3 milligrams per kilogram as a single agent, and if they saw 7 or more responses out of 19, then they would go onto the stage 2 where they would accrue more patients onto it. And in terms of the combination therapy, they used a dose that was deemed the best in terms of tolerability from the safety cohort, and that was nivolumab 3 milligrams per kilogram and ipilimumab 1 milligram per kilogram every 3 weeks for 4 doses, and then nivolumab 3 milligrams per kilogram every 2 weeks. And similarly, if they saw at least 7 responses in 19 patients, they moved on to the stage 2 and they expanded that cohort. So the primary endpoint was investigator-assessed response rate, and the secondary endpoint was to have independent radiologic review to assess the response rate. There were exploratory endpoints of safety and tolerability, progression-free survival, overall survival. The investigator-assessed response rate in the microsatellite stable patients, as well as some biomarkers. Now, I just want to reiterate that these are interim results. So I'm going to discuss the MSI high subjects first. So in the monotherapy arm of nivolumab 3 milligrams per kilogram, 70 patients were accrued. They didn't meet the initial endpoint to go on to the stage 2, so they ended up accruing 70 patients. In the combination arm, that is still accruing, and thus far they've accrued 30 subjects so far. And you can see here that the majority of people are still continuing on treatment, and there are some people that have discontinued treatment. The primary reason is disease progression. There were a few people that discontinued because of drug toxicity, or they withdrew consent, or for other reasons. I should also point out that the follow-up thus far is less for the nivolumab ipilimumab combination, because that cohort started accruing after the nivolumab monotherapy arm. So in terms of investigator-assessed best response rate, with the monotherapy arm, they saw a response in 25.5% of the subjects. With the combination, there was responses seen in 33%. Again, these are small numbers. No one had a complete response, but we saw, so all of these were partial responses. There was also stable disease seen in about 30% of the patients in the nivolumab monotherapy arm, and in about half of the patients in the combination arm. And there were some folks who had progression on this on these immunotherapies. The median time to response was about 2 months for the nivolumab monotherapy and 2.7 months for the combination arm. And the median duration of response is not yet estimable. These patients are still being followed. I should also point out that folks who were on this study for more than 12 weeks seem to have durable responses thus far. So you can see here for investigator-assessed progression-free survival, at 6 months, about 46% of people were still progression-free, and you can see same number in to 12 months in the monotherapy arm. And in the combination arm, 67% of folks were progression-free at 6 months, and the 9 month and 12 months are not yet estimable. So the median progression-free survival for the monotherapy arm was 5.3 months, and for the combination arm is not yet estimable. In terms of overall survival, you can see here in the MSI high population that the median overall survival was 17.1 months. And in the combination arm is not yet estimable, but these folks are still being followed. In terms of the safety cohort with the microsatellite stable population, there was one response seen in the nivolumab 1 milligram per kilogram with the ipilimumab 3 milligrams per kilogram, and none with the nivolumab 3 milligrams per kilogram and ipilimumab 1 milligram per kilogram. The median overall the median progression-free survival was about 2.3 months in the first combination and 1.3 months in the second combination, and overall survival 11 and a half months in the first combination and 3.7 months in the second combination. In terms of tolerability, in the MSI high population, these were the kinds of side effects one would expect to see with these immunotherapies. In terms of, you can see that the combination arm did have a higher percentage of side effects, and that parallels what has been seen with the combination versus monotherapy in other diseases as well. In terms of grade 3-4 toxicities, which are the kinds of toxicities that would cause us to lead to treatment discontinuation, you can see that more people discontinued because of toxicity on the combination arm compared to the monotherapy arm. And that is similar to what has been seen in other studies in other diseases with combination versus monotherapy. And so it was 13% in the combination arm and about 3% in the nivolumab arm for the grade 3 toxicities, but about 6% discontinued for any event. In terms of what kinds of toxicities were seen, here you can see. So this is in the microsatellite stable population in terms of the specific toxicity seen, and it does. So you can see that this was the safety cohort. This was the dose that was carried over in the microsatellite stable, in the MSI high population, because you can see that the number of grade 3-4 toxicities was much less than using the higher dose of the ipilimumab with the lower dose of the nivolumab. So now this study showed that in the microsatellite unstable population, both monotherapy and combination therapy showed intriguing responses, and they appeared to be durable. As I mentioned earlier, last year at ASCO, a similar study looking at MSI high colorectal cancer with pembrolizumab was presented, and they also saw responses in the MSI high population and not in the microsatellite stable population. The responses seen there were slightly high, were higher than what's been reported in this study, but keep in mind one has to be cautious with comparing one study to another because populations are not identical. The second trial that I wanted to discuss with regards to immunotherapy is abstract 3502. This is a combination of cometinib with atezolizumab in colorectal cancer. And so one of the challenges with colorectal cancer and immunotherapy is that these checkpoint inhibitors appear to work in the MSI high population, but what do we do about the microsatellite stable population, which is really the majority of metastatic colorectal cancer? I mean, it's great that something's working for a small population of the patients, but how can we tweak it so that the rest of the colorectal cancer patients can have a treatment that may work for them? So this is one approach. Cometinib is a highly selective MEK1/2 inhibitor. So the MEK inhibitor inhibits the RAS pathway, which is an important pathway in colorectal cancer and in a lot of other cancers as well. Atezolizumab is an anti-PD-L1 antibody, so it's another one of these checkpoint inhibitors. And so what has been seen in preclinical studies is that when you inhibit MEK, then you can get intratumoral T-cell accumulation and upregulation of major histocompatibility 1 in cell lines. And so the thought is that if you can bring in more of these immune cells to where the tumors are, can you make it so that these immunomodulatory drugs can have a greater effect? In preclinical studies, the MEK inhibitor with PD-L1 inhibitor resulted in increased tumor regression. So that's the idea behind combining these two agents in this study. This is a standard 3+3 dose escalation in solid tumors, but there was a predefined expansion cohort of KRAS mutated metastatic colorectal cancer. So there were a total of 23 metastatic colorectal cancers accrued onto this study. None of these were MSI high, but that they know of. MSI status was not required on this study, so about 70% they didn't know the MSI status, but about 30% were either MSI low or stable. They also looked at PD-L1 expression, and to later see whether PD-L1 expression correlated with responses or not. So in these 23 subjects with metastatic colorectal cancer, there were, you can see that there were adverse events that did lead to study discontinuation. They appear to be from the MEK inhibitor rather than from the PD-L1 inhibitor. So 4 subjects withdrew because of adverse events from the cometinib. And these events included things like nausea, vomiting, CVA. In terms of treatment-related adverse events, you can see here that there was a fair amount of diarrhea and rash seen, although significant diarrhea and rash were not very high. The one comment I want to make about rash is that, you know, people can describe a rash differently. So you can see that there are 3 different terms for rash here, and 21 patients actually had a rash, and 9% of them were a grade 3. In terms of efficacy, so I mentioned there were 23 colorectal cancer patients. 20 of them were in that KRAS mutant cohort, and the rest were in the initial expansion, in the initial dose escalation. And you can look at and see, so the response rates are 20% in the KRAS mutant cohort of 20 patients, and 17% when you look at all of the colorectal cancer patients. So it was 4 patients who had a response, and they were all partial responses. Didn't see any complete responses, and then about 20% had stable disease as well. And about half of the people progressed on this therapy, and about 10% were not evaluable. Looking at PD-L1 staining, the response did not appear to correlate with PD-L1 status. When one looks at survival and progression-free survival, so the median progression-free survival was 2.3 months, and the median overall survival is not yet estimable. These folks are still being followed. At 6 months, there were 77% of folks in the KRAS mutant cohort still alive, and 72% in all of the colorectal cancer patients. These were, in general, fairly heavily pretreated metastatic colorectal cancer patients. I'm going to go back. So while these responses are not as robust as what we have seen in the MSI high population, at least we are starting to see some responses in a population that we expect to, where they have very limited options, where we expect them to do poorly. And so I think that one has, so this is one step forward, but we clearly want to do better than that. In terms of chemotherapy, I'm going to talk about 2 abstracts in terms of chemotherapy. The first abstract is 3512, and this was a French study. It's a randomized phase 2 study in metastatic colorectal cancer with initially unresectable liver metastases. And this study is looking at, can you use a more aggressive chemotherapy to try to convert initially unresectable patients with metastatic liver metastases to resectable. These patients were stratified by RAS status, by metastatic sites, whether they had lung metastases, and why they were unresectable. Was it a surgical issue or an oncological issue? So patients were randomized to either arm A or B. And arm A, they got FOLFIRI or FOLFOX chemotherapy plus a targeted agent. Arm B, they got FOLFIRINOX plus a targeted agent. So FOLFIRINOX is a regimen that was borrowed from the pancreas literature. where FOLFIRINOX, which was a 4-drug regimen, was shown to be much better than gemcitabine alone. Previously, in colorectal cancer, there was a 4-drug regimen that had been studied called FOLFOX, and it was called FOLFOXIRI. Same drugs, but there was difference in terms of the dosing of the chemotherapy. And what the previous study showed was that FOLFOXIRI had much higher responses than FOLFIRI. And so here they're using this FOLFIRINOX plus a targeted agent, and so they want to see, can they increase the rate of R1 or R0 resection from 50% to 70%. I just want to explain, R0 resection is when the surgeon operates and the margins are clean and no visible disease is left behind. R2 resection is when the surgeon removes all visible disease, but when pathology looks at it, there's a positive margin. So in this study, what they found was that FOLFIRINOX with the targeted agent did have higher, did result in a higher R1, R0 resection rate, 56.9% versus 45.2%. The p-value is 0.062, so it did not meet statistical significance, and it did not meet the 70% that was that had been the primary endpoint of the study. They did have an improvement in overall survival, however, with the FOLFIRINOX with the targeted therapy arm. So in terms of overall survival, arm B, it has not yet been reached versus 36 months for the FOLFOX or FOLFIRI chemotherapy with the targeted therapy, and that was statistically significant. And that sounds good, but of course, when you add an additional chemotherapy, you increase the toxicity. And for regimens like FOLFIRINOX and FOLFOXIRI, these are regimens that have a high rate of neutropenia, and these are regimens that when I give it, I typically give it with growth factor support. And there is an increase in side effects with these regimens, and these are not regimens that everyone can tolerate. People need to be fairly robust in order to tolerate these regimens. It is something that that should be considered if one is trying to convert someone to resectability because of the higher responses. Because as we all know, in metastatic colorectal cancer, if the metastatic disease can be resected, 5-year outcomes are better. So we get very aggressive about trying to resect metastatic disease, and that also means that we get very aggressive about the chemotherapies that we use if someone is initially not resectable, but we think there's a chance of converting them to resectability. The next abstract I want to talk about is abstract 3521. This is the STAR-01. So this was a trial that had been reported some years ago, but they were reporting out the final results here. And I thought it was good to talk about this trial because, I just talked about the 4-drug regimen and how sometimes it's a good thing to use it. But I thought that this is a good trial to talk about to show that more is not always better. So for people with locally advanced rectal cancer, we typically treat with chemoradiation followed by surgery, followed by chemotherapy afterwards. And the chemotherapy that we typically use with the radiation is 5-fluorouracil, or sometimes we use capecitabine, which is the oral version of 5-fluorouracil. This trial was trying to see, can you use a more aggressive chemotherapy to improve your pathologic complete response rates. So they wanted to give FOLFOX with the chemoradiation and compare that to giving 5-FU with the chemoradiation. And what they had previously showed was that giving the FOLFOX resulted in significantly more side effects, but there was no improvement in the pathologic complete response rate. So this was a negative trial. When they looked at 5-year survival, there was no statistically significant improvement in 5-year overall survival. Numerically, it was slightly higher, but it was not statistically significant. So unfortunately, sometimes more is not always better, and sometimes it is, but not in this case. The other thing that was discussed at ASCO that I chose not to talk about here was there was a lot of discussion about right versus left-sided colorectal cancers and how the prognosis is different in the two of them. And there were several studies that they looked at, and what they showed was that the right-sided colorectal cancers had a worse prognosis than the left-sided tumors. And so I think that's interesting. I think it's hypothesis generating. I think that at this moment, it doesn't impact one's choice for treatment or one's choice for which chemotherapy one would use, but it is something that we should start thinking about in designing trials and perhaps in stratifying patients to different arms, because sometimes you do a clinical trial and your control arm may be much better or worse than what one would have anticipated from historical controls, and is it because of that factor or another factor that we hadn't taken into account in terms of randomization? So in summary, immunotherapy shows promise in MSI-high colorectal tumors, and the challenge is how do we sensitize the microsatellite stable patients? MEK inhibition in combination with PD-L1 inhibition looks promising. Certainly more work needs to be done. Certainly there are other compounds that one can look at in combination with these PD-1 or PD-L1 inhibitors to try to sensitize these microsatellite stable patients. And I just want to say that it's important to try to get onto clinical trials looking at this because it's only through clinical trials that we can move the field forward. A chemotherapy, more is sometimes better, but not always. The one other thing I want to make a plug about is that the NCI match trial is open again. This is a trial, sorry, this is a trial that looks at mutations in tumors and assigning therapy based on the mutations. And so this is another trial. This is another trial that that is trying to see whether, it's a national trial because some of these mutations they're looking at are very rare, but they're trying, and it's only by doing a large trial like this that they can accrue enough people with these rare mutations to see whether some of these targeted therapies can have an impact. Thank you.
Thank you so much, Dr. Chan. We'll go ahead and switch over to questions in just a moment. Okay. So as Andy mentioned earlier, if you have questions, you can type them in to the webinar platform online, and we can read them there. But Dr. Chin, we'll go ahead and start. If patients were to take away the top 3 meaningful topics from this year's ASCO, what can they do with that information moving forward?
Well, so I think that it's very important to get information about your tumor, not just what kind of tumor it is, but what's the microsatellite status, and if it's microsatellite, if it's MSI high, microsatellite unstable, I think that it's important to try to find a clinical trial for with one of these immunotherapies. If it's microsatellite stable, then I think that I'm always a big proponent for clinical trials because, again, this is how we move the field forward. But so far, the immunotherapies have been have not shown the same promise. And if one can get onto a trial, I would not want to. I would not advocate getting onto a PD-1 or PD-L1 trial on its own, but if you had it in combination with another immune modulator or perhaps in combination with chemotherapy, that would be worth trying. Or even other or other trials with chemotherapy in combination with other medication as well. The other thing is that there's that KRAS, BRAF, NRAS, we all hear about getting that information from the colorectal tumors, but there are these larger gene panels where they look at a lot more mutations. And if one is interested in participating in clinical trials, I would encourage people to get their tumors tested for those mutations as well, because because some trials are only accruing people with specific mutations, and that's because of the nature of the compound that they're looking at is targeting a specific pathway, and if one doesn't have that pathway that is misregulated, then one wouldn't expect the drug to work in it. Uh, um, Second take-home point is that, as I mentioned before, metastatic colorectal cancer we generally consider incurable, but there are exceptions. One of them is the when all of the sites of metastases can be completely resected. So if that is feasible, then it's important to get really aggressive about asking, well, is my tumor resectable? Is it potentially resectable? Because if it is potentially resectable, then one should consider more aggressive chemotherapy if one is in good shape for that, to try to shrink it down sufficiently so that a surgeon can go in and resect it. Now, I want to caution that even when one can completely resect all of the tumors, the likelihood of recurrence is high because it has already spread. But but there is a chance that it wouldn't come back, and that's why we get really aggressive about resection. Furthermore, even if it does come back, we know that 5-year survival is much better in people who can have that surgery as opposed to people who can't have that surgery.
Great, thank you. Let's see.
Dr. Chan, this is Andy Dwyer. Can you hear me okay?
Yes.
Sure, perfect. I know, you spoke a bit about, that there's things on the precipice of possibly telling us more information about what could be helpful in making treatment decisions. So left and right might be part of that. We know that, of course, looking at the biomarker status, especially with MSS, MSI, as well as the other gene panels. So we've heard a lot about, combination therapies, and I know that you mentioned that as well. Do you have a sense, and we're not asking you to be a fortune teller, of course, but I think if we're a year from now and we're looking at the things that could be probably the most exciting and relevant for patients that could see really good progress a year from now, what would you think that those would probably be based on what you know so far?
So that's an excellent question. I think that the data in immunotherapy is still emerging, not just for colorectal cancer, but even in cancers where the drugs are already approved. Because what we've seen with the immunotherapies is that the responses can be durable for a while. And it can be durable even and I'm extrapolating this from other diseases, but even when people stop the therapy, that response can last for a while. And we've all heard anecdotal reports that after immunotherapy and they go on chemo, sometimes the responses one sees on chemo seem better than what one might have expected. Those are all just anecdotal reports. I think that the challenge is to learn how best to use these immunotherapies, and I know that there are studies ongoing looking at immunotherapy in combination with radiation, and there are studies starting to look at immunotherapy in combination with other agents or with chemotherapy, because you could think of it, one of the hypotheses about why these immunotherapies seem to work in the MSI high populations, they have this bigger mutation burden. And so if you give radiation, you give chemotherapy, and you start exposing more of these neoantigens, do you then somehow um, make these immunotherapies more effective? And those are things that are all still being teased out, but I think that is an area that one needs to keep an eye on. The other areas are that uh, there's more and more um, people getting their tumors tested for mutations, and there's more and more studies with agents that target specific mutations. And like I said, some of these mutations are pretty rare. But at the same time, if it happens to be a mutation that is really important to the tumor and you can block that abnormal pathway, and we've seen this in some diseases, then that's something that is important. The other thing is that there are some KRAS, for example, is something that is considered not druggable, but I know that there are people still trying to create drugs against it or against other pathways in that arena, and that I don't think is going to happen in a year, but it's something to keep a lookout for as well, because KRAS mutations are about 40% of metastatic colorectal tumors, and if you look at pan-RAS, looking at NRAS and other ones, then if you look at the expanded RAS, that's about half of the colorectal tumor. So that's a big proportion, and we know that the patients with RAS mutated have one less regimen available to them, and their prognosis is less good.
Dr. Chan, you mentioned the MATCH trial earlier in your presentation. Can you explain a little bit more in depth what is the MATCH trial?
So yes, the MATCH trial is an NCI-sponsored clinical trial, and it's open at multiple centers around the country. And what this trial does is that people have their tumors mutation tested, and this has to be a recent biopsy within the past 6 months. And based on the mutation or mutations that are found, if any, they get assigned to a therapy if there's one that's appropriate to that mutation. Now, it may be that the tumor gets tested and they're not eligible for any of the arms. There's multiple arms in this matched trial, and the idea is not to put folks into these arms where the therapy is already FDA approved for their disease, but to look at other diseases where the therapy isn't approved to see if one can get the same activity in those diseases. It's it was open and there was a lot of interest in it, and then it closed for a while. Now, in terms of the arms, that's an evolving thing. There's more arms on there now than there was in the beginning. Um, there is also a recognition that colorectal cancer has less options available for them. So there are slots for colorectal cancer patients on the MATCH trial as well.
Great.
So, Dr. Chan, as a treating oncologist, things that we're hearing, a little frustration in the provider community as well as in the patient community is that, and I know that you talked a little bit about this, and Fight Colorectal Cancer, amongst many, talk about knowing your biomarker status. If someone at this, if patients don't know their biomarker status or didn't have tumors tested at this time, and let's say that maybe are in the throes of treatment, finishing out treatment, how would you recommend patients really think about obtaining information about biomarker status?
So I think they should start with talking to the oncologist because, and sometimes that information is available and they may have been told and forgotten, or sometimes they were never told, and sometimes it's not available. So two things. The when I'm talking about biomarkers and getting mutation tested, that requires a certain amount of tissue to get that done. And sometimes if all one has is a fine needle aspirate, there's not going to be enough tissue to do a whole panel of gene mutations, and you have to be thoughtful about what's going to be the most important, or should one consider getting another biopsy to get that information. Number two is that, I'm talking about this in metastatic disease, because in early stage disease where someone has been resected and they're being followed, getting a lot of that information about mutations and all isn't going to necessarily change what one does. The one thing that is important to get in early stage disease is microsatellite status, though. But mutation testing in that situation isn't going to be useful, and so not at this moment, at least, because the agents that we use for chemotherapy to prevent recurrence after resection are not based on any mutational information. The only thing that would have an impact is whether, is their microsatellite status. And so you don't want to over-test, but you don't want to under-test either.
Yeah. Yeah, no, I think, and Dr. Chan, I think that leads to something that we're going to be covering more is, there's a lot of different, and I know that you mentioned this, panels and testing, that at this time that there's some of those markers that people don't really understand if there's any clinical or treatment relevance. So I think your point around, over testing, or even sometimes to take it a step further, what these results mean, can be a little daunting for folks. So, that's something that we're planning to cover, because I know that in terms of panel testing and some of the work that's happening, there's the question about keeping that information to help progress science and to know, and then hopefully at some point be able to revisit that information with patients to see, what new and emerging topics or themes come from that knowledge base that they might have been tested for something that can help improve their treatment or matching the treatment options. But I think right now it's a little bit of the Wild West as we're trying to figure out how all of this fits together. But it's amazing opportunities based on, I think, what's happening. And I know that Sharon, myself, you as well as many got a chance to really look at the panel presentations, which at ASCO this year, I think, which was interesting to me, is it was the latest and hottest topics, not necessarily, the largest trials or the trials that had been in the field for the longest, but it definitely saw the trials that seemed to show the biggest gain in terms of even small patient, but ultimately looking at the biggest outcomes. So it was a really awesome opportunity to, I think, as you were saying earlier, to kind of think about the field and where this is going and growing. So had a chance to talk with Chris Liu, who helped moderate that presentation yesterday, and really excited about where the field is going. And then I think, Sharon, do we have any other specific questions that are coming up based on responses from people online today?
Yeah, just Dr. Chan, you had mentioned a trial that's opening up again. Can you just repeat what trial that is?
Was that the match trial, or were we talking about something else?
I believe it might have been the match trial, but I just wanted to confirm that there was not another one that you had mentioned.
Right, I was talking about the match trial.
Just the match trial.
Yeah.
Awesome. Okay. No, we're good on questions, unless, Andy, you had other ones that came in on your end.
I do. Sorry, I do want to, and Dr. Chan, I think if you just have a few seconds, we have been getting, and I've been getting offline, a couple of questions about the match trial. Could you just give a quick synopsis again of what match is looking for, and if any information about how, just in generalities, about how people might match to match, if that's an opportunity?
Sure. So it's open at a lot of cancer centers. Now, I think if one is looking for one that's open near them, I think you need to check at clinicaltrials.gov and see who has it open. So what the match trial does is, one needs to have a recent biopsy, and if there wasn't a recent biopsy, Match will pay for that biopsy. There's a certain, there's a limit to how much, so some of it depends on the cost of the biopsy at the institution, but, but, and then the tissue goes to the central lab that does the testing, and it takes a few weeks to get that result back. And once that result is back, if one has a mutation and it falls into a category where there's a drug and they're looking for and there's slots on it for that particular mutation with that drug, then one can enroll onto that as long as one meets all of the other eligibility. If there's no mutation, then then you won't get any treatment on that match trial. If one has more than one mutation, which sometimes happens, then there is a committee that there's basically a tumor board that decides which they would consider the most appropriate to assign the patient to. Was there a specific question about how that worked, or is it more just how does one get involved in the match trial?
I think that kind of sums it up, Dr. Chan. Thank you.
Yeah, I was also going to say that patients can discuss it with their oncologist, and they can also help refer them to a place that has that trial if they don't have it at their own site.
Great. Well, we just want to thank you again, Dr. Chan, for taking the time to review these ASCO trials with us and share all the updated information. And thank you to all the listeners out there for taking time out of your day to log in and listen. The webinar will be up on our website shortly, so if you want to check back in and listen again, you're welcome to. And I hope you all have a wonderful day. Dr. Chan, thank you again so much. We really appreciate it. Very useful information and very exciting science.
Thank you, and thank you for having me.
Thank you.